Okay, Assalamu alaikum, sabahkum al-khair, good morning. From here at Farah Healthcare Campus in Amman, Jordan, we say good morning to everybody, and we will start this session by presenting a case of aneurysmal bone cyst. As you know, the theme is the clinical, radiological, operative, pathological correlation. And our case for today is the 7-year-old male patient. That's back in September 2017, about a year ago. And the story goes that this patient, just 3 weeks before he presented to us, prior to admission, he had right eye proptosis with photophobia. That's the description of his parents. Father and mother says that we noticed this proptosis just 3 weeks before admission. In his past history, there is trauma here in the left frontal area, head trauma and cut wound scar in the left frontal area. Now, we don't know whether this is related to his pathology or not. We will see. But remember this. His vital signs were within normal. His general examination showed this. You can see the right eye is proptosed. It is pushed outward and downward. So right eye proptosis. This is when you look from the right side, you can see the right eye. See the difference? This is pushed downward and outward. And as we said always, that the proptosis is best seen if you look at the head from above. Even this is not good. We cannot really differentiate if it is minor. It should be tangential. So this is the only good way of looking at the eyebrow, to be at the tangent, and looking at the proptosis. He was 15/15 in Glasgow Coma scale. His eye movements were not restricted in all directions, so he had proptosis, but his eye movements were not restricted. No cerebellar signs.
Can we go back to the...
Of course.
We look at the right eye.
Dr. Ayman Mdanat, as ophthalmologist.
The eye is pushed down, but this is not called just pushing down. The whole eye, if you look at the whole eye, is moved.
Yes.
We call it dystopia.
Dystopia, exactly. And I left this terminology for Ibrahim Sadat because he's going to comment, and he wrote it as dystopia. So no cerebellar signs, gait was normal, no facial weakness. He can close his eyes and smile, so no facial weakness. There was no weakness in his upper or lower limbs bilaterally. And as you can see, this is a healthy young man. Chest X-ray and ECG. Chest X-ray was normal, ECG showed sinus arrhythmia. We'll come back to that later on. The question usually is raised, should we be doing an ECG for a child of 7 years? The answer, of course, obviously, is yes. CBC, bleeding time profile is normal. His creatinine was 0.7, and the normal, as you know, is 0.6 to 1.1. So why did I put it in red? Because this, for the patient age, is not normal. Liver functions were within normal. Imaging. We know we are talking about aneurysmal bone cyst, so we're not going to hide the diagnosis. So better know the aneurysmal bone cyst before we go into the imaging. First described by Lichtenstein and Jaffe in 42, and they classified it into a primary or secondary. Primary, and ما فيش أي pathology before. Secondary, there is a pathology, and then the aneurysmal bone cyst develops on top. The majority are primary. And in the majority of these cases, there is a history of trauma. And you have seen that this little boy had a scar of a trauma on the left side. He has the proptosis on the right side, but there is a history of a trauma to his skull, which goes with the pathophysiology of these aneurysmal bone cysts. Secondary, aneurysmal bone cyst developing on top of a pre-existing pathology. Giant cell tumor, osteoclastoma, blastoma, chondroblastoma, Langerhans, osteogenic sarcoma, etc. Lots of pathologies, they develop on top of them aneurysmal bone cyst due to trauma. So whether it is a primary trauma or a trauma on top of a pre-existing lesion, there is usually a history of supraosteal or intraosseous hematoma. So minor trauma or major trauma cause this little hematoma supraosteal or inside the bone, and then there develops inside the bone a high flow arteriovenous shunting like this. Once that happens, the arteriovenous shunting, the bone will get erosion, so there will be thin cortex, there will be bleeding, and there will be cavities, and these cavities are full of blood. Then the bone collapses and the soft tissue invasion begins. So it's not an easy pathology. So what would you expect in the MRI of the aneurysmal bone cyst? You will find a lytic bone expansion, there is eggshell cortical bone, heterogeneous appearance in T1 and T2. You will find cysts with the fluid levels, and you will find septations, and these septations take contrast enhancement. So to summarize the pathology of aneurysmal bone cyst, it is a blood-filling sponge, bubbly appearance. What is this way? مريض تحت ليه؟
هلا
كيف حالك؟
صباح الخير.
So this is the MRI of this patient. You can see this lesion. It is involving the medial wall of the orbit. It's involving the whole of the ethmoid. It's going into the sphenoid. Give contrast. There is contrast enhancement of the septations, multicystic cavities, as we described in the pathology. It's going intracranially. This is frontal sinus being involved. So there is intracranial lesion, but look at this, fluid level, because these are cavities filled with blood, which is caused by the pathology that we described. This is T2, multiple cavities, septations, and we are reaching to the sphenoid sinus. Of course, here the ethmoid is gone completely, so you'd expect that the lamina papyracea here is gone, so the medial wall is gone of the orbit. T2, different stages. This is intracranially. And this is the coronal view. You can see the intracranial extension. Now, if you know the pathology of these lesions, usually they don't involve the dura, they don't invade the dura. So you may say this is intracranial extension. I would say no. This is a tumor pushing the dura above. That's important because this is important in planning of the treatment. But multiple septations, multiple cavities, reaching to the maxillary sinus. So maxillary sinus is involved, medial wall of the orbit, ethmoid completely, as we said, intracranial extension without a dural impeachment. The roof of the orbit here is gone. So medial wall, roof of the orbit, roof of the ethmoid, and the whole of the sinuses. Multiple cystic fluid lesion. Here we are in the sphenoid, in the area of the anteroclinoid process. And this is the sagittal section, again, the septum, the maxillary sinus, the ethmoid, and the intracranial extension, and the sphenoid. T1, T2. Multiple levels. Remember, this patient is lying on his back, so the fluid level is this. Fluid level, multiple. This is pathognomonic. This can only be aneurysmal bone cyst. There is no other diagnosis. CT show you this bone being eroded in the roof of the orbit. Again, how much of the bone erosion is here in the ethmoid, in the orbit, sphenoid. Amount of bone destruction here. Again, I always point to this. The radiography technician is not controlled, and he writes names and things here. Pathology is here, so why should you write something in here? Destruction. Maxillary sinus. The roof of the orbit is gone. again here the anterior clinoid. This is anterior clinoid, lesser wing of sphenoid. This is the orbital fissure. So we are involving here the orbital fissure, the anterior clinoid, destroying them completely. The sagittal CT showing the bony destruction. So now we understand the images because we understood the pathology. And this is the 3D CT. You can see the thickening here in the ethmoid sinus and the ethmoid plate. This is the lamina papyracea being crushed upon, severe orbital fissure, and the bony destruction there. We always do the MRA and MRV to complete the images to see the pathology better. There was no abnormality in that. So what's the differential diagnosis of this lesion? Although, as I said, the images are pathognomonic. This is an aneurysmal bone cyst, multicystic lesion filled with blood, etc. But what is the differential diagnosis? So wide. Malignant tumor, sino-nasal squamous carcinoma. By the way, this is the commonest malignant tumor of the sino-nasal group. Adenocystic, adenocarcinoma, undifferentiated carcinoma, owing sarcoma, the nasopharyngeal carcinoma. They look like our lesion, but they are in the same location, but they are different pathologies. Rhabdomyosarcoma, osteoma. Whenever you see arrows, these are not my cases. This is from Osborne Book of Radiology, but the others are my cases. Osteosarcoma, osteoblastoma, giant cell tumor, Clivus chordoma, one of my cases, chondrosarcoma, metastasis, lymphoma, esthesioneuroblastoma, ossifying fibroma, inverted papilloma, which is the commonest benign tumor of the sinonasal area, sinonasal fibroma, again one of my cases, and angiofibroma, neurofibroma, histiocytosis, etc. Intraosseous meningioma, sphenoorbital meningioma, hemangiopericytoma, epidermoid, fibrous dysplasia. The pathology is very, very wide. So to understand what you are going to do, you have to make a proper diagnosis. Mucocele, one of the commonest cases that come to the ENT clinic. Giant cell granuloma, fungal infection. This was a Libyan chap with this major fungal infection. Allergic rhinitis, echinococcus, hydatid disease affecting the orbit, and the inflammatory pseudotumor. So these are grouped together as sinonasal lesions or tumors. Why they are called so? Sinuses and nasal. Nasal cavity and paranasal sinuses are involved. They are lumped up as one sinonasal tumor. They like to invade via the route of least resistance, so they go into the cavity, the paranasal sinuses, the nasopharynx, lamina papyracea, cribriform plate, and so on. They account for 3% of all head and neck tumors. 3%. As we said, the commonest tumor is squamous, the commonest benign is inverted papilloma. So we did a few consultations for this boy. Dr. Ibrahim, you are here, I've seen you coming, please.
Good morning. I had the pleasure to evaluate this lovely kid, and when I say lovely, he's a really lovely kid. And the situation is sad. He's lovely and he has this disfiguring and bad tumor, and he was not born like this. It happened just a few months ago or something like that, a few weeks ago. So we as ophthalmologists, Dr. Ayman knows, Dr. Sura knows, we don't like to deal with kids, especially when they have this neurological problems, because we have a lot of complex tests to do. So we refer them to pediatric ophthalmologist. So unfortunately, I'm a pediatric ophthalmologist as well. So I referred him to myself, and I continued his examination. When I saw him for the first time, his vision was counting fingers in the right eye. He was unable to do more than this. His left eye was perfect. Color vision is important. He was 0 out of 17 in the right eye. Left eye was 16/17. Visual fields were full in both eyes. I could not do automated visual field at that time, but I managed to do this by finger confrontation, and he was full to counting finger. And with fundoscopy, there was no papilledema or optic atrophy. In the optical coherence tomography, there was nothing of the nerve fiber layer in both eyes, with minimal changes in the ganglion cell layer. And this is the OCT. We evaluate many areas in the retina. This is the macula, the ganglion cell complex, and there is an automatic software that will tell us whether there are significant changes or not. So this is the right eye. There is no significant change compared to the change in the color vision and visual acuity. This is the left eye.
Yes.
Minimal changes as well. And we expect to have some structural changes with that decreased visual function, counting fingers, visual acuity, and zero color vision. We expect to have some. So we don't have much of a structural change in the optic disc. This is the optic disc analysis. The machine counts the nerve fiber layer around the optic disc, and it is good. So this is an indication for us that if we intervene, usually I don't write impression because sometimes most of the time the cases are straightforward, we want just to document, but sometimes I write my impression. And this is my impression. There's a right optic neuropathy and proptosis that seems recent because the structure of the optic disc looks normal while the function is subnormal. This indicates that surgical intervention should be carried out soon in order to improve vision. If we don't hear this message, the patient will go blind in a few days to a few weeks. So if you listen carefully, you might hear the voice of the optic disc. Please, Dr. Sbeih, help me and intervene in 1, 2, 3 days, something like that.
Thank you. So Raymond, do you want to comment on this?
I think what Dr. Ibrahim said, he's covered the whole subject. Just when we are assessing, as you said, we assess the motility. Motility was full, and this is strained. While there's a tumor pushing from the nasal side. As I said, there's dystopia. If you put a ruler horizontal
line,
you will see that, and it's always good to measure how
much is the proptosis in millimeters?
It is mentioned actually.
Yes.
There was some
Yes.
sort of limitation, and there was some dystopia as you raised this.
I want just to stress what Dr. Ibrahim said. That
Yes.
This was said beautifully by Dr. Ibrahim. Is that the optic
Ibrahim, you mean?
Ibrahim Sbeih. I love you both. So the optic nerve. There's an optic nerve fiber swelling, but they are not dead yet.
Yes.
If it was left, they will be dead. But thank you for Ibrahim. You've done a great job here.
Dr. Sarah, you want to comment?
No.
Thank you. Any neuro-ophthalmologist? Okay. We consulted our pediatrician at that time. It was Edward Saka, because, as you said, creatinine is 0.7, and for him, this may indicate renal failure. So it's minor thing, but it's important for kids to remember creatinine 0.7 is high for the patient age. So he said we'll repeat this because this is high for his age and weight. And we repeated it was 0.5, so he said it's okay. We asked Dr. Aouni al-Madani, I don't know whether he is here. Dr. Aouni? No, we asked them to come because we did a cardiology consultation because of the sinus arrhythmia, and he considered this to be okay. It is not really pathological, and we can proceed with the surgery. So pediatric cardiologist, Dr. Aouni al-Madani. Anesthesia, patient was announced fit for general anesthesia, American Society of Anesthesia Grade 2. Dr. Aisha, you are here?
Yes.
What does it mean, American Society of Anesthesia Grade 2? Dr. Aisha is the anesthetist in this house.
صباح الخير جميعا. طبعا the ASA classification has been developed by the American Society of Anesthesiology. It's a simple and actually a quite reproducible method for assessing the risk of surgery for patients presenting for us for surgery. He's been classified as ASA2 because ASA1, these are patients who are completely fit and healthy, they have no chronic medical illnesses. As for grade 2, which means they have medical illness, as in this guy, in this boy, so he has a tumor, so we classify him as grade 2, which means his health is controlled and the condition he has no effect on his physical status. As in grade 3, as opposed to grade 3, these patients have some limitations in their physical activity. As in grade 4, they have a constant threat to life. Meanwhile, grade 5, they have constant threat to life, whether they have surgery or they're present for surgery. And the American Society of Anesthesiology added the letter E in case the patients actually present for emergency surgery.
Okay. Your seat has been taken, so you can sit there. So what is the difficulty in treating surgically aneurysmal bone cyst? What are the difficulties there? Usually it affects young group of patients, and young group patients are growing patients, so you want to take care of their sinuses, their bones. Blood loss is very high. Accessibility is difficult. We are talking about skull base. So these are the difficulties which we will see in the video coming. So sinonasal tumors in general are almost always treated by surgery. What kind of surgery? Either craniofacial approach like you will see in our case, or by endoscopy. Exceptions, lymphomas, multiple carcinomas, they are treated by chemo and by radiation. So surgery is the upfront treatment of these cases. It is microscopic surgery. It is not done by the naked eye. Neurosurgery is microscopic surgery. If you see a neurosurgeon operating with his naked eye, he is living in the Middle Ages. And the aim is total resection whenever, and it is applicable. So you don't just go for radiological triumphs. I have to remove the tumor regardless of what happens to the patient. So you want to do total resection with respect of the health of the patient. Some anatomy of the area we are going to, we are going here, in this area. This is the orbit made of 7 bones, 7 arteries, 7 veins. This is the greater wing of the sphenoid. This is the process of the maxilla, process of the frontal bone, nasal bone, maxilla itself, superior orbital fissure, inferior orbital fissure. The lacrimal sac is here, so anatomy that you should remember. A magnified view, greater wing of the sphenoid making the lateral wall of the orbit, the superior orbital fissure, up to the optic canal is there, and here is the lacrimal sac. This is the maxilla. So this is the nasal septum. This is the medial wall of the nasal septum, right or left, and the lateral wall is actually the medial wall of the maxilla. You have to remember this anatomy and then put this soft tissue on top. You have to remember what is the medial canthus ligament because it's important. If you cut the medial canthus ligament, you can remove or move the whole of the globe and go to the medial wall. And one thing to remember is the lacrimal sac and nasolacrimal duct. You have the superior inferior canaliculus going to the sac. So you can mobilize the whole thing this way so that you will go this way. So here we've cut the medial canthus ligament, and this is the sac and the sac and the duct. And once you do that with the retractor, you can move the whole thing, come to the medial wall of the orbit, which is the lamina capriccia of the ethmoid bone, and you will face the anterior ethmoidal artery and more posteriorly the posterior ethmoidal arteries. Both are branches of the ophthalmic artery. You have to know the anatomy of the sphenoid bone, made of body, greater wing, lesser wing. Lesser wing contains the optic canal. Between the lesser wing and greater wing is the superior orbital fissure. The body of the sphenoid contains the sphenoid sinus. It has 2 legs, the medial and lateral pterygoid blades, and they are articulating with the hard palate, with the palatine bone. All this anatomy should be in the back of your mind. If you go more, this is the orbit, this is the maxillary sinus, this is the infraorbital nerve going in the roof of the maxillary sinus. So the medial wall of the maxillary sinus is the lateral wall of the nasal cavity, and it contains the turbinates, inferior turbinate, middle turbinate, and superior turbinate. The nasolacrimal duct opens here. The duct or the drainage of the maxillary sinus goes here in the middle turbinate. Again, the septum, inferior turbinate, middle turbinate, the maxillary sinus. We are going back to the posterior wall of the maxillary sinus. And if you remove that, you will come to the pterygopalatine fossa. You can see pterygoid muscles, you can see the pterygoid ganglion. Again, here you start to see the eustachian tubes. If you go further down, you'll come to the infratemporal fossa, and you'll see the maxillary artery and all the nerves there. Should one know this anatomy, if one goes into this lesion, it is a must. You don't leave it to the ENT colleague or the facial maxillary. As a neurosurgeon, you should master this anatomy. Again, the relationship of the maxilla that articulates with the palatine bone, that articulates with the pterygoid plates, is very important. Here is the nasal septum, maxillary sinus on the left, maxillary sinus on the right. So the medial wall of the maxillary sinus, which is this, is the lateral wall of the nasal cavity. Septum, medial wall of the maxillary sinus, infraorbital nerve. Why I'm mentioning this? Because you're going to see this in the video. So medial wall of the maxillary sinus with the turbinate. And if you remove that, you will come here to the nasal septum and into the sphenoid ostium and sinus. We will go there, you will see this, you will see all this anatomy that we mentioned. Constant form should be detailed, and we have to describe what exactly we are going to do. Myself and Dr. Sartawi are doing the surgery, what is the patient complaining of, and the most important, that the aim of surgery is to remove the tumor completely, but this is impossible from a practical point of view. You cannot remove every simple piece of tumor in the skull base. The aim of surgery is to excise as much as possible, and this is all depends on what we find during surgery. This is very important for the patient family to know. And you mentioned the complications. Complications are really high, 30%. CSF leak, infection, bleeding, brain catastrophes, even death. So this is the anesthesia. It's a nasal intubation. This is myself, Sartawi, and the patient being carried by his father. And Dr. Abaisha, again, why nasal intubation? Why not usual?
Good morning again. بصراحة موضوع nasal intubation has been a topic of debate for the longest time. I think in this case maybe the anesthesiologist has decided to choose it because in pediatric patients it's much more well tolerated post-operatively, and on awakening the patient they are much more tolerating the tube while awake. With all honesty, I wouldn't dare going for nasal intubation in this case. As Dr. Ibrahim Sbeih mentioned, the tumor was in close proximity to the nasal cavity, especially the ethmoidal sinus and the maxillary sinus. It's a very highly vascularized area, and the complications of nasal intubation is tremendous, especially torrential hemorrhage. And in pediatric age group, the adenoids are large, and you don't want to compromise the other nasal cavity, especially that the right nasal cavity is involved with the tumor. It has its proponents and opponents, especially going with the complications. The major indication for nasal intubation is to go with the dental surgery, and if the patient has severe trismus, and in case of difficult intubation, using awake fiber optic intubation. I was not involved in the management of this patient, so I wouldn't comment on what my colleague has done. But if it was up to me, I wouldn't go for nasal intubation.